I'm Harriette Van Spall, and I'm delighted to be here at ACC 2023 with Dr. Amrita Mukhopadhyay from the New York University Grossman School of Medicine. And she is here to present the results of the Better Care HF trial. Welcome, Dr. Mukhopadhyay.
Hi, thank you so much for having me. I'm very excited to be here.
We're going to start this discussion by asking you to frame your trial in the context of the medical literature so far. Tell us about the problem of implementation of guideline-directed medical therapy in heart failure and what the rationale was for your work.
Absolutely. So as many may know, heart failure is a major public health problem in our country, and we have multiple medications that can help improve lives for these patients. However, there are huge gaps in the patients who are receiving the therapies that are guideline recommended. So, for example, mineralocorticoid receptor antagonists, which is the medication I focused on, also known as spironolactone or eplerenone, are some examples. I'll refer to them as MRA. So, up to 65 to 75% of patients who are eligible for MRA may not actually be prescribed this medication, and closing this treatment gap could save over 20,000 lives per year across the United States. So this is sort of a major gap in care that I wanted to focus on, but you kind of hit the nail on the head with your question as far as how do we actually close this gap? There are so many things that could be causing this gap, and closing it is a real challenge. So one potential solution is EHR tools, and these can be scalable and low cost and really improve prescribing for medications. But there has been some hesitancy or mixed findings with EHR tools. So a recent meta-analysis found in an overall this is a recent meta-analysis of other tools used for other medications. They found a 4.4 percentage point improvement across studies. So it's sort of a small but significant improvement. And then there's wide variability. There's many different ways that EHR tools can be developed, and the optimal delivery and design of these tools is currently unknown. And so the goal of this study really was, one, can we develop an EHR tool that can reduce this very important and significant gap in care? And what is the best type of tool to use? So we developed two tools, which I can tell you more about, but one of them being an alert and one of them being a message, and really tested those two against usual care.
Right. So we have some background knowledge that decision support can be effective at improving uptake of guideline-directed medical therapy. The recent PROMPT HF trial showed the efficacy of EHR alerts. And your trial went a step further in testing two different interventions relative to usual care. Tell us about those interventions and your hypothesis.
Yes. So the two interventions were alerts and messages. So alerts are, different EHRs have different ways of creating alerts, but the real thing that distinguishes them is they're at a single visit, they're for a single patient, and I think of them sort of as sort of push notifications. I think most physicians are probably familiar with types of alerts within their health system. And the drawback of alerts is that they can interrupt workflow. You might be opening a chart to do something else, and then you see this alert, and that's just going to interrupt it can interrupt your thought process. And then the other drawback is a term called alert fatigue, which is very common. A commonly used term called alert fatigue, where, if you are just bombarded with a lot of alerts, or you're bombarded with alerts that are not necessarily accurate or representative for your patient, you might just start ignoring them, which I often do for example, the push notifications on my phone. I ignore them. If there are alerts that I know are often inaccurate, I might ignore those. So those are sort of the drawbacks of alerts. Too many alerts can be bad, and they can interrupt workflow. Messages, on the other hand, they can include multiple patients at a time. Unlike alerts, they are usually seen in between encounters. Usually a physician, when they're looking at a message, it's a little bit of a separate time. They're not with the patient or talking about something in real time, but maybe might have more time to think about it because that's, they've opened the message specifically to look at it, and that's sort of the task at hand. But the drawback of messages being, like I mentioned, the patient might not be there. So you may have to do something like call the patient or have them come in. And then another drawback of messages like alerts, too many messages and you might start ignoring them too. So, I think we've all had that experience of having too many emails and struggling to get through them all. So those are kind of a big picture overview of the two types of interventions that we created. I think some very important developmental features of our interventions. So first, they were highly selective. So they only targeted patients who would be most likely to benefit from MRA specifically. They didn't fire if there was signs of hypotension, hyperkalemia, renal dysfunction, documented MRA allergy or intolerance. And so I think those features really, the goal was to get the alerts and messages to fire as few times as possible to sort of reduce those things like alert fatigue, like I was talking about before. And then the other thing was we really targeted cardiologists because they were the ones seeing the patients with heart failure in our health system, and they are the ones that were really sort of involved in making the decisions around MRA therapy. And so those are two features. And then we also used a variety of we used a whole host of sort of pilot testing, semi-structured interviews, and refinement to really develop our interventions. We took concepts from cognitive load theory, nudge theory, 5 rights of clinical decision support, and essentially those are to try and make our interventions less burdensome to providers, to help tap into the psychology of human decision making a little bit, and to also make sure that these interventions are going at the right time in the workflow to the right patients, et cetera. So I think that's a little bit about our design and development of the two interventions that we created.
So a 3-group parallel cluster randomized trial with cardiologists who served as the clusters of randomization, and you tested an alert message at the point of care versus multiple messages around several patients between their clinical encounters or usual care. Is that correct?
Yes. Yeah.
So tell us about the baseline characteristics in each of those groups. And presumably your analysis was at the level of the patient, while the randomization was at the level of the clinician.
Our final sample size was 2,211 patients. And, a little bit about our cohort, the median age was 73, 71% were male sex, consistent with the epidemiology of heart failure, 69% white race, 11% Hispanic ethnicity, 69% Medicare insurance. We actually had a lot of patients already on background beta blocker, ACE, ARB, and ARNI therapy as well. And the majority, so about 75% of our patients were being seen by either a general cardiologist or a heart failure specialist.
Fantastic. Now tell us about your primary outcome and your results.
Absolutely. So our primary outcome was the percent of MRA eligible patients with newly prescribed MRA during the study period. So in the usual care group, this happened for 11.7% of patients, compared with 15.6% of patients in the message arm and 29.6% of patients in the alert arm. And when we conducted analysis accounting for the clustered nature of the data, there was a significant improvement in prescribing in the message arm as compared to usual care. But I think what's most striking is when comparing the alert arm and usual care, the alert more than doubled prescribing of MRA as compared to usual care. The alert was also more effective than the message.
Okay, and remind us where these centers were. Were they within a given region or across the country in the US?
Thank you. That's a great question. So this study was conducted across NYU Langone Health, which is a very large, diverse health system in the New York and greater New York area. We have over 60 cardiology practices, and there's a wide range from academic tertiary care practice to community-based practices with a pretty wide catchment area.
Okay, and were there any incidents of crossover where the same patient might have been receiving care from two different clinicians, or where fidelity to the intervention wasn't complete?
Yes, that is a great question. So as is expected for pragmatic studies, this is sort of being conducted in the realm of a normal healthcare system, and patients have the ability to see who they want to see. So we did have some patients seeing multiple physicians, and the percentage of crossover, or the percentage of patients seeing multiple physicians was around 14%. And what we did to sort of deal with this is we also conducted a sensitivity analysis that excluded these patients, and had, pretty much the same results.
Okay. What were the safety endpoints that you assessed?
Thank you. So we also looked at hyperkalemia, and we defined it in two ways. Hyperkalemia being a side effect of MRA. So first we looked at potassium levels above 5.1, and then we looked at what we called severe hyperkalemia, or potassium above 5.6. And we did find some increase in hyperkalemia in the alert arm above 5.1, but not any difference when looking at severe hyperkalemia of 5.6. I think in one way it's slightly reassuring, because I think it actually means that it's not just we're prescribing more of MRA, but patients are probably actually taking the MRA. So I think that's also sort of another step in the line of improving care, of prescribing and then adherence. So that's good. And then I think it's reassuring that, the number of patients with potassium above, severe hyperkalemia was similar between arms.
Sure. So how are you going about implementing your findings at these health centers and beyond?
Yeah, I think there's so many possibilities with this work, and I'm really excited about our results. I would hope to be able to definitely implement this across our entire health system. I think working in other settings would be phenomenal. I think also translating some of our findings into other areas of cardiovascular care is a huge possibility as well. For example, atrial fibrillation or MI, et cetera. And then finally, I think one thing that I want to sort of draw caution to is the more, sort of the alert fatigue phenomenon. So I tried to design this so that it was as few alerts as possible. But then if we start doing things with other disease processes, I think it'll be interesting to note, how does this go long term? So this was a 6-month study, but what happens after a year of these alerts? Do physicians sort of start to ignore them at a certain point or not? And then what happens if there are other, alerts or other EHR tools that are added into the mix for other disease processes? Does that then impact the efficacy of this one?
Right, because of comorbidities, even within a single population, if you choose to have alerts for heart failure, but also hypertension, maybe diabetes, you might have multiple alerts around the comorbidities, even for a single patient. So a really important practical consideration for implementation. Thank you so much for sharing the results of your trial with us. Congratulations to you and your co-principal investigator. And I can't wait to see you in person at ACC.
Thank you so much as well. And thank you for having me.